Welcome to the core objectives in gross anatomy. This is the first section of the upper limb module entitled the upper limb bones. My name is Suarez-Quian. I am the creator of this video and will narrate it for you. As I and others before me have stated, gross anatomy is the science of the obvious. It is the vernacular that is used to describe the structures of organisms. What makes it difficult in the present day is that Romans and Greeks got to describe structures in the language of science that was used in their times, Latin and ancient Greek, languages that are no longer part of our vernacular. Thus, we're left to memorize the names of structures using this archaic language. In 2007, a number of anatomists from England wrote a series of logical objectives that students should master. The first author of this article is named McCanwell, and the work appeared in the Journal of Anatomy, Volume 11. As such, let me read the objective that will be presented in this video and is shown in the next slide. Describe and demonstrate the main anatomical landmarks of the clavicle, scapula, humerus, radius, and ulna. Recognize the bones of the wrist and hand and their relative positions. Identify those bones that are commonly damaged, for example the scaphoid and lunate, and predict functional impairment following such damage. First, I will describe the bones of the upper limb and then follow up and give an example of common fractures of some of these bones. Let's begin. Here's an image of the bones of the upper limb. In addition, note that bones of the thorax, for example, the sternum, ribs, and vertebrae, are also present. In general, bones serve as attachment points for the muscles of the upper limbs. Since muscles that move the upper limbs also attach to the clavicle, sternum, and vertebrae, by definition, these bones are discussed when studying the upper limb. Let's begin by first identifying the bones of the upper limbs. The clavicle, the scapula, the humerus, the radius, the ulna, the carpal bones, the metacarpal bones, and finally the phalanges. Now that we have identified the bones of the upper limb, let's describe some of the specific features of each bone. First, look at the three bones that make up the pectoral girdle, that is, the bones that bind the upper limb, what lay people would call the arm, to the central or appendicular skeleton. These three bones are the sternum, the clavicle, and the scapula. We will discuss the clavicle and the scapula in this section. The sternum is generally described when the region of the thorax is studied. I will start with the clavicle. The clavicle is a long, slender, and curved bone that extends from the sternum to the scapula. It exhibits specific details as follows: the sternal end, the acromial end, the conoid tubercle, the shaft of the clavicle, and the groove for the subclavius muscle. The clavicle acts as a strut, which holds the arm away from the trunk. It also serves to transmit force from the upper limb to the axial skeleton, and it provides attachments for muscles. To demonstrate how a strut functions, let's draw an A-frame house and observe how the strut provides structural stability to the roof. The construction of a simple A-frame begins with the placing of a structural support at the center of the structure. This is known as a king's post. Next, walls are erected. And finally, the roof is placed to extend from the king's post to the walls. Although this simple A-frame house can provide shelter from the elements, it is minimally stable. Any strong wind could easily knock down the structure. The walls of the A-frame can be reinforced by adding tie beams from one wall to another. The force of tie beams on the walls helps to keep them erect. However, the roof is still at the mercy of strong winds or excessive weight, for example, a heavy snowfall. By adding struts, the roof is now well supported and is kept at the appropriate location to maintain the roof line. This is precisely how the clavicle functions to keep our shoulders away from our trunk region, allowing the arm to swing freely past our thorax. To further illustrate this point, let's look at what happens when the clavicle is fractured. Here's a drawing illustrating the wide angle that is present between the arm, the shoulder, and the scapula. The only reason that the arm can swing freely past the trunk region is that the clavicle, acting as a strut, keeps the shoulder region away from the trunk. Now imagine what will happen if the clavicle is cracked, as shown in the next image. Falling on your shoulder may crack the clavicle at the location indicated by the red squiggly line. Shown in the next image is the result of such a fracture. The force of gravity pulls on the free hanging upper limb in a downward direction, indicated by the long black arrow. However, this is not all that happens. The clavicle no longer acts as a strut for the shoulder. The pectoralis major muscle, a major adductor of the upper limb, now has no opposing force to keep the shoulder joint located away from the trunk. Its basal tone adducts the shoulder joint towards the trunk, indicated by the two blue arrows pointing towards the scapula. At the same time, the proximal portion of the clavicle is raised by the unopposed action of the trapezius muscle, shown by the two red arrows. Let's now look at the scapula from the front, a flat, nearly triangular shaped bone. The scapula exhibits two borders, three angles, and various processes. Let's take a look. The medial border, the lateral border, the superior angle, the inferior angle, and the lateral angle. The suprascapular notch, the infraglenoid tubercle, the coracoid process, and finally the acromion. We now take a look at the scapula from behind to observe different structures, but as well observe similar structures as before. The superior angle, the inferior angle, the medial border, the lateral border, the spine, seen only on the back of the scapula, the supraspinatus fossa, the infraspinatus fossa, the glenoid cavity, and once again, the acromion. We now look at the longest bone of the upper limb, the humerus. Both its anterior and posterior views are shown in the image. I will now identify the prominent features of this bone. The head, the anatomical neck, the greater tubercle, the lesser tubercle, the intertubercular sulcus, or the bicipital groove, the surgical neck, the shaft of the humerus, the deltoid tuberosity, the medial epicondyle, the lateral epicondyle, the trochlea, the capitulum, the coronoid fossa, the radial groove, the olecranon fossa, and finally the groove for the ulnar nerve. As you probably know, either from direct experience or that of friends, the humerus bone can and does fracture. Furthermore, the close proximity of specific nerves to distinct areas of the humerus makes these nerves susceptible to injury when the particular part of the humerus is fractured, as follows. If a fracture occurs at the surgical neck, the axillary nerve may be injured. If a fracture occurs at the radial groove, the radial nerve may be injured. If a fracture occurs at the medial epicondyle, the ulnar nerve may be injured. And if a fracture occurs at the distal humerus, the median nerve may be injured. The deficits resulting from specific nerve injury will become apparent as you become cognizant of nerve function in the upper limb. Let's now take a look at the two bones of the forearm, the ulna and the radius. The ulna articulates with the humerus at the elbow joint and helps to stabilize the forearm. It is at this joint where flexion and extension of the elbow joint occurs. In the anatomical position, the radius is located laterally, that is, on the thumb side of the forearm. In this position, the radius is said to be in supination. When the hand is turned face down, indicated by the curved red arrows, as when putting your palms on a table, the radius is said to be in the prone position. Let's look at specific features of these two bones. Shown in the image are the radius and ulna from the front, the anterior view, and from the back, the posterior view. Look at the ulna of a left forearm. The olecranon is located proximally on the ulna on its posterior surface. Anterior to the olecranon is located the trochlear notch. It articulates with the trochlea of the humerus. On the anterior surface of the trochlear notch is the coronoid process. When the arm is flexed, the coronoid process can fit into the coronoid fossa of the humerus. Inferior and lateral to the coronoid process is the tuberosity of the ulna for attachment of the brachialis muscle. The styloid process of the ulna is located distally on the medial aspect of the bone, whereas the head is located on the medial aspect of the distal ulna. Let's now focus on the radius. The head of the radius is located at the proximal aspect of the bone to articulate with the capitulum of the humerus. Below the head is the neck of the ulna. Below the neck and on the medial aspect of the radius is the tuberosity. It is the point where the proximal part of the radius is recognized as distinct from the shaft. Finally, there is a styloid process of the radius. It is located laterally on the radius. Before moving on to the bones of the hand, let me describe a common fracture of the forearm bones. The wrist bones are aligned in a straight line with the distal radius and ulna as shown in the image. A common fracture that occurs at the distal and radial ulna is known as a Colles fracture. The fracture alters this alignment. The breaking of the bones happens when we fall on our stretched hands and the force is transmitted from the palm of the hand to the distal radius and ulna. The approximate fracture line is indicated by the red line. Note that the line crosses the distal radius and ulna, and both stylus processes exhibit the potential of being broken off. The net result of the fracture is to completely separate the distal radius and ulna along with the wrist and hand bones from the shafts of the radius and ulna. Now look at the alignment of the shafts of the radius and ulna relative to the distal wrist and hand that is no longer articulated. The now free distal bones have been drawn upwards and backwards by the extensor group of muscles, indicated by the red arrow. The alignment of the broken bones resembles the alignment of a fork. Indeed, the condition is often referred to as the silver fork deformity by orthopedic surgeons. The next set of bones we need to examine are the wrist bones or carpal bones. The carpal bones are arranged in two rows, a proximal row and a distal row. Let's identify these bones. Starting on the lateral side of the proximal row, we find the scaphoid bone, ancient Greek for the name of a boat. Next to it is the lunate bone, Latin for moon-like. Next in line is the triquetrum, or tri-shaped. Finally, there is the pisiform, or small p. You should be able to palpate this bone on yourselves. We now move to the distal row and observe the most lateral of the bones, the trapezium, Latin for multi-shape. Moving medially, we see the trapezoid, so called because it resembles a trapezoid. Next is the capitate, so called because it has a little head, or caput. The last bone is the hamate. It has a hook and is known as the hook of the hamate. Let's look now at the relationship between the distal end of the radius and two of the carpal bones, the scaphoid and lunate. Note that these are the only two carpal bones that directly articulate with the radius. Hence, any force transmitted from the carpal bones to the radius will take place via these two bones, precisely what happens when one falls and catches themselves on an outstretched hand. Commonly, it is the scaphoid bone that fractures at its distal end. What is unfortunate for fractures of the scaphoid bone is that it receives its blood supply in a retrograde fashion. Look at the radial artery. Note that it gives off one small branch to the scaphoid bone to the distal pole of the bone. The scaphoid receives no blood supply from the pole that is adjacent to the radial bone. This relationship has implications for when the bone fractures. The common site of fracture of the scaphoid bone is shown by the blue line. If the fracture tears the blood supply to the proximal pole of the bone, this part of the bone can undergo avascular necrosis after the fracture. Avascular necrosis, as the name implies, is tissue death due to loss of blood supply. Fractures of the scaphoid are difficult to discern in radiological images immediately following the fracture. After a couple of weeks, if the bone dies, the proximal pole of the bone loses its radiodense properties. At this time, the radiocarpal joint becomes unstable. Let's now focus on the digits. Digits are labeled 1 to 5, with the first digit being the thumb. The metacarpals corresponding to digits 1 to 5 are also labeled from 1 to 5. The metacarpals are the bones that make up the palm. Metacarpals 2 to 5 are well supported, and if they are fractured, rarely do they need to be placed in a cast. Distal to the metacarpals are phalanx, or phalanges, if used as a plural. These are the bones found in the fingers. The first bones, distal to the metacarpal, are called the proximal phalanx. The bone distal to the proximal phalanx is called the middle phalanx. And the bone distal to the middle phalanx is known as the distal phalanx. All joints between a metacarpal bone and the proximal phalanx would be known as a metacarpal phalangeal joint, or MP joint for short. The joint between the proximal phalanx and the middle phalanx is known as the proximal interphalangeal joint, or the PIP joint for short. The joint between the middle phalanx and the distal phalanx is known as the distal interphalangeal joint, or DIP for short. This now concludes the first section of the upper limb module, in which the bones of the upper limb and some common fractures of these bones are described.